So, welcome to our afternoon panel session on global health and pro bono, the universal right to health in COVID-19, as part of our inaugural conference on current trends and themes at the juncture of rule of law, pro bono and international development. As you may know, here at A4ID, the work we do in channeling legal support and pro bono towards development projects responds to a wide array of challenges in the framework of the UN Sustainable Development Goals, or the SDGs. The SDGs frame how we approach development and understand the impact of our work. It was somewhat tricky to decide which of the broad array of development challenges that through our partnerships A4ID grapple with needed attention as part of our conference. Yet at the same time, it was absolutely clear to us that given the state of the world over the last year and a half and the effects, impacts and challenges to human well-being highlighted through the COVID-19 pandemic, that health and well-being covered by SDG 3, which includes targets on creating universal health coverage, and global health justice would be essential topics for our schedule. Our panel of esteemed experts brings to the table both expertise in global health as well as the legal and policy context of these issues. I know that each of one of our panelists are currently actively involved in work to promote health justice in the context of global vaccinations and other justice issues related to the pandemic. We hope you'll find it inspiring to consider how you might find your way to contribute. We very much welcome your questions and are keen to hear from the audience. So please do use the Q&A box in the Zoom to submit your questions and also to upvote other people's questions if you'd like to hear, if you're keen for the panelists to respond to these. If your question is chosen for response, then we will contact you to ask whether you might like to deliver that question to the panel yourself and give you the opportunity to unmute yourself. This is, of course, entirely optional, and also to give your views on the topic as well as part of the discussion. So we do hope you'll find it a very stimulating session to explore the issues and contemporary global developments about an issue that we've all been affected by, and ask you to consider how, as a legal practitioner, you might contribute to real needs in times of crisis. So to lead today's panel of esteemed experts, we give a very warm welcome to our panel chair, Robert Yates, who is Director of the Global Health Programme and Executive Director of the Centre for Universal Health at the Policy Institute Chatham House. He is an expert on universal health coverage and progressive health financing, and recently was involved in work progressing an agenda in political support towards equitable distribution of COVID-19 vaccines, as many of our panel have been as well. I'll just introduce the rest of the panel before handing over to Rob. So we have Dr. Aisling McMahon, Assistant Professor at Maynooth University Department of Law. So Dr. McMahon is a specialist in medical and intellectual property law. She is particularly interested in the regulation of emerging biotechnologies and the relationship between intellectual property and bioethical concerns relating to health-related technologies. Her recent work has certainly contributed to understandings about vaccine development and distribution. We have Dr. Huan Hu, Senior Legal and Policy Advisor for the Access Campaign of Médecins Sans Frontières, or Doctors Without Borders, with a focus on access to medicines and intellectual property. She's also a postdoctoral research associate at the School of Law at SOAS in the UK. And lastly, we have Umanyana Rugegi, Executive Director of South African NGO Section 27, a human rights organisation that seeks to achieve substantive equality and social justice. She is a human rights lawyer and has been with the organisation since its inception in 2010. So welcome to you all, and welcome especially to Rob Yates, who can take over.
Thank you very much indeed, Naomi, and it's an absolute pleasure to be with you. And regrettably that we can't meet in person like we have in previous years. And obviously this is due to the COVID crisis, a health crisis, and which is impinging everyone's lives at the moment, and is sort of the hottest political issue in town. I'm very sort of keen this afternoon that we have a good lively discussion around the right to health and universal health coverage, and really how the COVID-19 pandemic has affected those sort of two great ideals, the right to health and universal health coverage. And I'm sure in the next hour and a half, we're going to be sort of discussing, how that's threatened those things, how sort of potentially population groups have been left behind, left out, not getting vaccines. There are some fairly obvious areas whereby we're not fulfilling the right to health at the moment. But it's Friday afternoon. I think we should be optimistic as well. I think we should be thinking about this potentially providing some opportunities to change this. We are living in very volatile times, sort of politically, if nothing else, and that we have seen things like the COVID pandemic see the back of President Trump, really. That there've been sort of potential change in the political atmosphere in the United States, and maybe even with a view to health reforms in the US. So we're very keen to explore with you this afternoon what is happening vis-a-vis the universal health coverage and the right to health, and how things might change going forward. And as Naomi mentioned, we're very keen to get your views on this and encourage you to ask questions in the Q&A function. So don't use the chat function, if you use Q&A. And then if someone asks a particularly good question, you might want to upvote it, and then we can see the more popular questions rise to the top, and then we'll sort of try to ask those of our panel first. So it was just before the pandemic started, really, that all world leaders got together in New York at a high-level meeting on universal health coverage to say that, everyone should get the health services they need without suffering financial protection. Every country in the world is signed up to this ideal. But I'd like to sort of, ask my fellow panelists in their introductory remarks, how do you think we're succeeding in this respect in this COVID pandemic? And where are you sort of seeing examples of us moving towards or away from universal health coverage at the moment and the right to health? And if I may ask my panelists if they'd be happy to talk for, say, 5 to 10 minutes, giving introductory remarks. And obviously we can take this conversation in lots and lots of different ways, because there are so many ways it impinges on the right to health and universal health. I'll perhaps ask 1 or 2 questions and try and get a bit of dialogue going between the panelists, but all this time wanting our audience to participate too. And the best thing still would be for you to come online and in effect join the panel, to ask a question. That would be fantastic. But Aisling, if I can start with you, what's your thoughts on COVID-19 and pandemic and how it's impacting on the right to health and universal health coverage?
Thanks for the question. Thanks again for having me here today. I'll just say before I start, in the interest of full disclosure, I'm also I am an assistant professor of law in Maynooth University, and I'm also a member of the voluntary group Access to Medicines Ireland. But any comments that I make today obviously will be my own personal capacity. But I think that's a really important question. I think it's really good that we're actually here today to talk about some of these issues, because obviously COVID-19, in my view, and I think in most people's view, would be the biggest global health crisis of our time, or certainly in living memory. It has affected all nations. It has had huge implications, both in terms of the lives lost, sadly, and also economic, social effects and impacts. And I think everybody globally really wants to get to the stage where the pandemic is brought under control. That's really in all of our interests. There's also increasingly an acknowledgement that the best way to tackle the pandemic is by having global access to vaccines for everyone. And not just vaccines, I suppose also other health technologies, diagnostics, but in particular to bring the pandemic to an end or under control, we need access to vaccines. And I think it's interesting in the COVID-19 context, and obviously in every other context, there should be a moral imperative, is my view, that there is access to healthcare for everyone. But COVID-19, I think, is different, because there is that moral imperative, but there is also a pragmatic imperative. And the pragmatic or the self-interested rationale is that global access to vaccines, we know, is needed for everyone in order to bring the pandemic under control. So it's in our interest in the UK or Ireland or Europe or wherever that we have that global access. But yet, despite the fact that we have this moral imperative and we have the right to health and we have legal obligations and we have the pragmatic imperative, my sense is that the current fears, they still remain, that there is this vast disparity in access to healthcare for COVID-19. And actually COVID-19 has shown us some of the reasons, and it's put a kind of spotlight on some of the issues in this context. And I just want to touch on one of the issues that I suppose I'm been working on the most this last year is the intellectual property issues, and how COVID-19 and how IP rights in particular have enabled or entrenched some of the inequalities as I see them in the access to healthcare context. And these were inequalities that were evident before COVID-19, but they've been particularly put in the spotlight, I think, by COVID-19. And just briefly, as I know we'll touch on these later, but just briefly in terms of intellectual property rights and the right to health, I think there can be a conflict which has come out in the COVID-19 context. And intellectual property rights such as patents, as we are aware, they allow the rights holder to stop others using technologies potentially that are under patent. And without the rights holder's permissions, that can mean that others can't produce those technologies. So we've had a situation over the last year where we've had a limited supply of vaccines and other health technologies. And we've also had a situation where intellectual property rights have enabled, they're not the only problem in this area, certainly not, but they've also enabled a situation where rights holders effectively have been gatekeepers of health technologies, of vital life-saving health technologies. And that has been and is a significant issue in this context. And we've seen it right across the spectrum in terms of diagnostics, in terms of medicines, and I suppose most significantly recently, and indeed throughout, in terms of vaccines. In the diagnostic context, just to give one example, towards the kind of March, April side of the pandemic, in spring, we had a situation in the US which developed at that time where one patent holder threatened another that they would actually prevent them from providing diagnostic testing for COVID-19 because they claimed it infringed their patents, which is really interesting. And eventually that led to, as you can imagine, a huge amount of public backlash against that decision. This was the height of the pandemic, and the challenge was dropped. So it didn't actually materialize, but it just shows you that within even this health situation, and even where we all are agreeable that we need diagnostics, you have these situations emerging where private intellectual property rights are potentially could be used to be an impediment to access to diagnostics. Similarly, there are examples that I could give in the medicines context. And most recently, since we've had the approval of vaccines, which is fantastic that we've had these vaccines and sciences delivered, but unfortunately, many of the vaccines were bought up relatively early on by the higher income countries, and there has been a huge disparity in access for low and middle income countries. And there's also a situation where many would agree that there is an artificial scarcity in that more vaccines could be produced if we had greater sharing of data, of know-how, of intellectual property rights. There have been global systems and schemes set up to do this. So the World Health Organization had the CTAP, which is the COVID Technology Access Pool, which was set up to try and bring countries and also companies together in this spirit of solidarity to share IP, to share know-how for not just vaccines, but also diagnostics and medicines. But just over 40 countries worldwide have actually endorsed that pool, and not many high-income countries have endorsed that. Similarly, no intellectual property rights holders of vaccines, for example, has actually committed to working with the pool to date. Now, there have been recent pushes again for CTAP, but although that system is there has been limited engagement by rights holders with it. We've also had, situations where, given the lack of access to vaccines and given the need to rapidly upscale them, we've had some manufacturers trying to engage with some corporations, some of the rights holders to increase production. Now, there have been some successful bilateral deals, but there's also been some situations where, despite manufacturers stepping in and trying to get licensing agreements, they were unable to do so. So voluntary solutions to date have not been entirely or at all indeed effective and to get that rapid upscaling of manufacture that we've needed. And alongside that, there's been mandatory solutions which have been suggested, such as the TRIPS waiver, which I'm sure we'll come back to discuss. Over 100 countries worldwide support that, but still many high-income countries are blocking it. So I suppose all in all, the COVID-19 pandemic, I think it has shown this spotlight on access to healthcare, on the needs to have access to healthcare, but it's also shown the vast inequalities that still remain throughout the world. And it's shown some of the problems, I think, that law and that we as lawyers need to address, in particular issues around intellectual property rights, not just IP, also other issues in terms of transparency of contracts, transparency of agreements in terms of how countries negotiate for access, and also some of the power dynamics that exist in that context. And I'll probably just stop there because I'm sure we'll come back to touch on some of those issues later on.
Brilliant. Thank you very much, Ashley. You set us up perfectly there. And I don't think there could be a more stark failing of universal health coverage than the whole issue around sort of COVID vaccines and technologies, sort of where, we've got this absurd situation that, we're potentially vaccinating children here in the UK, and you know, people like myself will be entitled to a booster shot, I think, in the autumn. And you know, you've got health workers in Uganda and across the world, you know, really not getting, you know, these vital services. So I'm sure this is going to be a sort of a hot topic we're going to discuss, and I've certainly got some questions I'd like to ask you about CTAP and things like that. But I think that's an excellent segue immediately into the work that you're doing, Juan. And I know that the Médecins Sans Frontières are very engaged in the battles around equitable distribution of vaccines, and through organizations like the People's Vaccine Alliance. So what's your perspective, you know, sort of sitting in Geneva, sort of close to the heart of global health, you know, how do you see it going, and how potentially can the legal profession support initiatives to improve an equitable distribution of products?
Thank you so much, Robert, and thank you, Aisling, for the wonderful starting point to frame the legal issue. So I will share my screen for 2 minutes and then come back. Oh, disabled sharing the screen. So I want to show a map, and then we start talking about the inequity. Thank you. So I can share now. I want to share 2 slides that we normally use. Why MSF is very active in this pandemic, not because we're working with people, but the work I'm doing as the senior legal and policy advisor on a daily basis is really touching the kind of soul of MSF movement when we try to see the injustice we witness in the field also can be used as kind of supporting, empowering people's voice, asking for change, not charity. So I just want to show this map, and I will close my window. This map is basically related to a movement globally asking for waiving certain intellectual property related to COVID-19 health technologies, and some of the movements happening in South Africa and India, civil society community groups protesting in front of embassies of Germany and other embassies, asking Japan, US, EU to not blocking this discussion. And the map to the left, to the right-hand side, shows where we are. And I think many of our colleagues also think this is actually a very telling story of the access experience we are witnessing now together in this pandemic. It's not just about a map of what happened among WTO members. Talking about this specific waiver proposal, it shows how inequality and inequity are manifesting in this normative discussion, when the map also shows who gets what in terms of vaccine and technology and medicines. People who have more resources and wealth in Europe now become the final hurdle for the whole world to move forward and diversify and democratizing the access to knowledge and technology in this pandemic. So I'll stop sharing now, come back. Thank you. So yeah, in MSF, as you said, Robert, we have been responding to the pandemic in more than 70 countries globally since the beginning of the pandemic. Not just treating and providing care for people who are affected, but also to make sure the essential health care services are least interrupted. It's been very challenging from what I heard from our medical teams. Even MSF is an organization who's been through many health emergencies in the past and worked with some of the most challenging epidemics such as Ebola. That's not the whole world is working, but we are working with those epidemics. But the pandemic of COVID-19 is something special. It's unprecedented even for organizations like us who consider ourselves have some experience. No, our experience is totally not enough. We have been constantly facing shortage of supply and procurement hurdles to get even the basic health supplies. So now everybody talking about vaccine, but in many of the projects, we don't even have the basic supply to have ventilators, oxygen concentrators, masks, and PPE, when many countries in the West and maybe other country already overcame that kind of shortage from last year. And when it's come to vaccines, many people don't even know what vaccine looks like. As Ashley said, we are facing this challenge of holding the life-saving actually knowledge and technology by a few companies who are backed by the intellectual property monopoly and further backed by the government who are hosting them when we have the opportunity to do something differently, and a small group of government are not allowing developing country to seek self-reliance. So those are the kind of reflection for us, the reflection of the historical and structural power asymmetry and inequality, discrimination, colonial treatment to developing countries when the world is running into the crisis. Collectively, we are experiencing very different access issues in the population we are serving. So when it comes to vaccine access, now there's also multiple layers of complexity and legal issues related. The intellectual property is one, because for us it is the root cause that need to be addressed when we are talking about allocation of the existing vaccine, which is already challenging because there's so far no global mechanism that are mandatory and enforceable, that are binding to prevent country from going whatever they want, to fight over limited resources. When we see rich countries are holding majority of the vaccines, leaving others empty-handed, the only mechanism globally available to aiming to facilitate distribution is the COVAX facility and the access to COVID technology accelerator kind of coordinated by WHO. But increasingly, we see a failure emerging from the COVAX operation precisely because the inequality underlying the whole operation of this kind of design. And the design itself also doesn't empower more countries to produce and supply themselves. And there's no mechanism to prevent rich country from drawing doses from COVAX at the same time and not supplying more, not providing more supply options. So we are experiencing this as a humanitarian sector that normally we're at the very, very back, at the back of the queue, because the population we are working on are the most marginalized. Many of the population are not even covered by the formal health system. We're talking about internal displaced people, refugee camp, and other marginalized population, minority groups who probably don't have normal access to healthcare before the pandemic already. And now, the global system is not covering this in an adequate manner. And we now face also a very concrete hurdle to access to vaccines because of the liability immunity requirement from a pharmaceutical company. We know in the past 1 year, this kind of a liability immunity requirement have been pushed through in developing countries when governments want to have a procurement concluded. And for the moment, as a humanitarian sector, we face this liability pushing to us that we cannot actually handle. And then also the population we serve are lacking of legal representation in general. So if anything happens to us related to adverse effect on vaccines to them, when there's no government coverage, when we cannot cover, they will be left unprotected as a whole. So there's a huge legal hurdle there when it's come to finishing the last mile delivery of vaccines to the people we are serving. So overall, we are looking at very frustrating access situation, but we see a lot of rooms that the lawyer and advocate can play a huge role in this situation, because we are facing the present challenge that we have this normative discussion in WTO. There's a lot of technical issues. The lawyer can play a role to help justifying and analyzing. but also we face the concrete legal hurdle when it's come to contract and licensing agreements and trade secret and undisclosed information claim, how to find the legal revenue to overcome those claims in the global pandemic will be very realistic legal issue to tackle. And we also face as I said, lastly, the liability problem, when last year the excuse was we didn't have enough data, but now we have more data. How to legally speaking, making this mechanism more accountable to the industry rather than pushing everything to people will be a question for us to engage. And we also think that the present challenge should also inform us for longer term reform so that we could have a more just kind of legal and policy framework in the future pandemic. So I'll stop here. Thank you.
Great, thank you very much indeed. And I think really excellent that you're flagging that many of these issues now are definitely more political and legal than they are scientific. You know, you've had the UN Secretary General, I think, sort of saying that the scientists have succeeded and that the politicians are failing. And you know, these are issues now around the allocation of scarce resources and how that's done. And, you know, that's much more in the political and legal sphere. So this is why we're so delighted that legal colleagues are interested in participating in these debates. In many respects, the scientists have done their jobs. They've come up with these amazing technologies that work. They just need to be allocated more efficiently and fairly now across the world, which we're patently failing to do. And if I may now turn to you now, Umanyana, and you're based in South Africa, and of course, you know, South Africa is a country right at the forefront of these debates. And, you know, that we've seen President Ramaphosa being sort of one of the leaders calling for TRIPS waivers and sort of taking this fight to the World Trade Organization. And also just before sort of coming on air, we were sort of discussing the vaccine rollout situation in South Africa and your scarcity of vaccines at the moment. So what's your perspective? You know, in Section 27 have been sort of fighting for the right for health for ages now, and very successfully involved in the fight over HIV medicines. You know, so where do you see this debate going in South Africa in the coming months?
Thanks, Rob, and thanks to my fellow panelists. I really appreciate being on this panel. And it's always interesting to talk to lawyers because you can kind of have a different language than when you're in a different sphere. So welcome to everyone on this call. Yeah, so in South Africa, we have been heavily affected by COVID-19. Right from the beginning, we had some of the highest numbers in the continent in terms of cases and deaths. We're closing in on 60,000 deaths as of right now over the period. And I think what's also quite clear is that although there was, you know, our government was lauded for its initial response, a quick lockdown last year in about March, and kind of very strict curtailment of freedoms. There was no alcohol sold for a while because they wanted to make sure that the hospitals and in emergency rooms were left free for COVID cases. So there were a number of interventions that were lauded. This was done through the law. So we have a disaster management legal framework. Sorry, my sound is a bit low. Okay, I'm also sharing the space, so it could be that. So initially there was that kind of use of emergency law in order to kind of do the lockdown. And very early on, we began to raise concerns about human rights and the fact that there was serious curtailments of rights where people were locked down in places where they couldn't reach services, which was really critically essential. And there was this kind of very police-driven, militarized response to people. And there was a criminalization of people who were just trying to make their way through a serious lockdown where they couldn't make a living because the economy was essentially closed. And at that time, we started talking more about human rights, and we tried to emphasize that the government actually needs to work with communities, with the most affected people. In this kind of emergency, that is necessary. And that's a lesson that we've learned from HIV, is that people have to be at the center. Human rights has to be the fundamental approach to what is a public health crisis. And so what we tried to do initially was to make sure that those voices were heard. And also we started talking about intellectual property and access to medicines, because that's another area that we're very familiar with. Rob mentioned the fight against HIV and the work that we've done to advance the right to health in South Africa. And you probably know that South Africa was one of the most affected countries in the early kind of HIV epidemic. And we had to fight the legal battle against the pharmaceutical companies to open up access to antiretroviral treatment. Now, this treatment was available in the world, as COVID vaccines and treatments are available in the world, but they were not available to the people who most needed them. And that led to significant deaths. The estimation is that 300,000 people died unnecessarily because they simply didn't have and could not afford antiretroviral treatment. So we're in the very same position, and there's a real need for the use of the law and the creative use of law. Based in the Constitution in South Africa, we have a right to health that places an obligation on the state to take the necessary steps to advance those rights. And what we have to do is really to address the structural barriers to accessing healthcare services. And one of those things is the TRIPS waiver that Rob, you've just mentioned, which has been championed by the South African government together with the Indian government, and is now supported by over 100 countries, mostly developing countries. And so the developing world is essentially saying, this is what we need. This is what we need. We need to be able to expand manufacturing capacity. The kind of lack of vaccines now is an artificial scarcity, as Aisling has said. And in fact, there is capability to manufacture those vaccines around the world. There are companies prepared, ready and prepared to do that manufacture. And in Africa, actually also led by our government in South Africa, there's a move by the African CDC to begin to build that manufacturing capacity, not only for COVID, but for future pandemics. And we're talking about future pandemics because we think that's essential. But we mustn't forget that the developed world is far ahead and is talking about recovery, whilst Africa is mostly in the third wave of COVID-19 and is not on the other side. In fact, only about 1 to 3% of populations in Africa have been vaccinated, and that's purely because of the lack of vaccinations, even through COVAX, which was meant to be that solidarity mechanism. Which has failed Africans, essentially. And we're starting to see more and more strident comments about the fact that COVAX has failed, mainly because rich countries have utilized that process and said, yes, we're doing solidarity, we're giving vaccines away, but at the same time have taken up every vaccine available in the world, to the extent that only 1 to 3% of African populations have been vaccinated as of now.
Great, thank you very much indeed, Unya. And I'm delighted that you mentioned in such detail there the battles to bring HIV medicines to Sub-Saharan Africa. And one thinks that, we're here again, it's exactly the same story 20 years on. And I've just put in the chat, which hopefully participants can see as well, a link to a superb film, if you haven't seen it, about the tactics used by civil society organizations, including Section 27. And I know that Oxfam was very involved in this as well. And a masterful sort of piece, whereby at one point, I think the pharmaceutical companies were going to have President Mandela, back in the dock again. In fact, in the very dock where I think he'd been sent down to Robben Island, if I'm not mistaken. And this was just obviously a complete public relations nightmare for the pharmaceutical industry, and they sort of capitulated really after this, and that this resulted in generic medicines being imported from India, and the price coming right down and saving millions of lives. So one feels that we're back here again. It's sort of exactly the same discussion again. And what's it going to take to turn this around? And I think if you just want to see how manifestly we're failing on this score, it was the G7 summit that the UK hosted just a couple of weekends ago, where there was this great call from world leaders and Dr. Tedros and even the IMF and the World Bank were all saying the same thing, sort of about the urgent need to share vaccines immediately, that because they're all sort of in countries like ours, and they need to sort of get overseas, but more than that, to provide a lot of public financing to procure more medicines and vaccines and also diagnostics. But also, and we've been touching upon this, the technology transfers, the fact that too much manufacturing is concentrated in the West and there isn't enough. And we've mentioned, the patent waivers is one thing that will facilitate that, but more is needed in terms of building capacity and training and other areas. And really on all three scores, the G7 leaders did practically nothing. I mean, it was, laughably bad. So I suppose an immediate question for you all, and I'm glad to see one or two questions coming in as well. I very much encourage others to ask, but what is it going to take to get the G7 leaders to take this agenda more seriously? Because, expectations were running high, I think, before the G7. President Biden had announced that the US was going to support a patent waiver, and I think there was a hope and expectation we were going to do better. But I mean, the G7 was a disaster, really, but, sort of on many scores. The G20 will be coming up in the autumn, but, millions are going to die before that even. But what is it going to take, do you think, to get our leaders to take this more seriously? Would any of you like to volunteer? And it's a tough question because, and it's something that, a number of us are racking our brains on, what are the tactics that are going to work? And potentially, how can the law help with that? I mean, that if they won't listen to sort of arguments about common decency and being responsible human beings, what is it going to take to get them to change? So any volunteers from the panel to sort of take that on in the first instance? One, what do you think from MSF's point of view? Is it sort of, what are the tactics that might work, do you think?
Okay, so I will probably comment both from an MSF perspective, but also as my own. So there's some position we did our international president put out a statement. I mean, as representing us on the G7 disaster, as you said, if we can put that way. I mean, to really outline how this becomes more and more. I mean, I would see irrelevant to the suffering from people on the ground. This is basic. We know it's a rich country club, 7 countries, the most wealthy country, who have been holding vaccines and supporting industry to hold the technology and the knowledge, making empty promise, we would say, or not unrealistic promise. And then when people in the developing world are dying. So we are very frustrated about this setting, representing again the historical and structural problem in the international governance structure when it's come to health. When we see, Rumiana rightly point out, and it's a human rights issue, it's an individual suffering, it's a community suffering. It should, the right-based approach, looking at a more bottom-up approach to for accountability. What the G7 is doing is in a bubble and out of touch and out of any accountability that other people can hold on them. But from the legal perspective, it's probably hard because it's a club. So that the club running by themselves, following their own rule and their narrative and worldview about how what should be running. And to our experience, and also maybe representing myself a little bit more for the moment, it's we need to probably come back to multilateralism as a government, especially in a global crisis. Now we heard more and more analysis how small group decide what's good for the others, whether others don't even have a voice on that, and to have a state to hold. So when it's come back to the multilateralism, and that probably is some obligation, even in soft laws perspective, for country to stay in solidarity and respect each other and support each other. I mean, that is how the access to medicine vaccine issue has been called out not only by the DG of WHO, but also by the Security Council, by the Secretary General of UN, reaching to the level of a security concern. So if we are kept fighting over vaccine and other resources in the health arena, it probably will cause other consequences when the economy, social welfare continue to get declined and destroyed because of this small group of countries' behavior. There should be some global accountability there to check. I'm not quite sure which one, because there's no hard law there to check, but that probably the one step to do is coming back to multilateralism.
Mm-hmm. Yeah. Well, one would hope that that was happening. It's just the alarming progress on that front, isn't it? That we keep going from summit to summit, and World Health Organization, Health Assembly, and it just doesn't seem to be happening yet. But maybe the UNGA. Let's see. Aisling, Emiliano, did you have any sort of thoughts on sort of what it's going to sort of take to get this club to behave better?
Yeah, I don't mind to answer. No, I think it's a really important question, and I think it's something that, certainly since the start of the pandemic, like we all could have predicted, sadly. It's really sad to say that, but like all of us probably working in the access to medicine space could have predicted that this was going to happen. And that is awful to say that as a group of lawyers. I mean, even look at the report of Human Rights Watch, which I think was published in October 2020. And, when you read it and you see what was outlined there and you see what people were writing at the time, and sadly, a lot of it's actually come to pass, this idea of shortage of vaccines, of shortage of access, and we've continued to allow it to happen. And I think all of us, what can we do to change it? I'm at a loss, because I think there's been so many excellent voluntary initiatives like CTAP. In my mind, when it was first proposed, that was a promising initiative. It was asking countries to come together and also asking pharmaceutical entities to come together to say this is a global pandemic, it's have devastating impacts, it's going to get worse, we need to have some sort of solidarity, and we need to ensure that there isn't an artificial scarcity, because I think that's the key point. It's not about, I don't think it should be about who gets access, it should be about everyone should get access, because in reality we can actually upscale. We know that there is indications from groups like Knowledge Ecology International who've done a study, and they've seen there is potentially excess capacity there, that we could actually increase capacity. So we know that it is possible to do it. We just need, as Yuan said, to come together to figure out how to do that, to come together. But unless there's a will, really there's not going to be the way. I think that's the problem here. How do we get countries to actually come together? And sadly, and I hope this doesn't happen, but sadly, it's the time of crisis. If the crisis gets worse, is that what will be needed? I hope that is not the case. I really genuinely hope that there is action. And I think there is, the US support for the waiver. That was, an historic moment. And it has led to greater, I think, focus on what initiatives are needed. And it has also led, and a few of us have worked together to publish a paper on the TRIPS waiver, which we argue that it is necessary and proportionate at this time, that we need it because the voluntary solutions have failed. But what we also say in that paper, and I'll post a link to it in the chat, is that the TRIPS waiver, not only is it an important legal tool, it's also an important lever. And since the waiver, the US has supported, albeit a narrower waiver, they're suggesting that they'd support a waiver for vaccines only, not the broader waiver that was initially suggested. But nonetheless, that has encouraged, I think, some kind of movement. And you've had some more voluntary licensing deals, and we've had the recent suggesting that there will be a technology transfer pool set up. So we've had some movement, but we need to see much, much more of it. And I think we have to kind of say that we need all obstacles taken out of the way. So not just IP, because that's just one part of this puzzle. We also need kind of supply chains. We need to agree on that, to coordinate access, to make sure that everybody that can produce has that access. We need to have things like transparency around the contracts. I think that could illuminate some of the issues, and that might actually highlight to the public more, because the public are getting really engaged, and the people's vaccine movement shows that, and other movements. But the more we have transparency, the more likely some of these issues might be teased out. And then alongside that, we need things like regulatory data to be sort of shared. We need the sharing of that data. We need to do all of these things and many more. And also maybe to encourage technology transfer, doing things like paying companies, if necessary, doing whatever we can to get them to come on board, but even including investing to making sure that we have that technology transfer to bring up this capacity. So, I don't have the answers, but I think we need to have a broad-ranging solution, and to go back to multilateralism, and importantly, to develop sustainable solutions. This is not about sharing doses. I think it's about actually building capacity in countries. And the TRIPS agreement, when we think back at the history of the TRIPS agreement, one of the commitments within TRIPS under Article 66 is that actually developing and least developed countries would be enabled to increase their technology capacities to build their industries. That promise, I don't think, has been fulfilled. I think most would agree it hasn't been. So we as lawyers, I think, can actually look at the TRIPS agreement and look at those elements to it, and what can be done to increase capacity, and what obligations do states have to ensure that is done now.
Yeah, exactly. And I mean, CTAP is a very interesting thing, because I think it was initially suggested by the president of Costa Rica, and Costa Rica has got a great universal health system and very progressive. And many, I think, thought this was a sort of a great idea, but it just hasn't got off the ground, has it? Because that no pharmaceutical company has gone anywhere near it. What would it take to get them involved, do you think? I mean, perhaps public financing. Do you think that were they sort of paid to sort of participate, that could sort of start things off in the right direction?
Perhaps CTAP, this was something that was raised, I think it was, certainly by the president of Costa Rica. It was May that it was launched officially, I think, but it was initially a suggestion by Costa Rica, and then launched with the World Health Organization. And the idea behind it was really that one of solidarity, coming together, bringing companies, bringing countries together to support the sharing of IP data, know-how, knowledge, to get, for all, not just vaccines, diagnostics, medicines as well. But there's been two things. First of all, I think we have to, when we talk about CTAP, countries haven't supported it. There's only been just over 40 countries worldwide that have supported, and the full list is on the WHO's website. So in order for it to be successful, it needed, and it still needs, greater support from states, and particularly from high-income countries, which, by and large, many of the countries, there have been some high-income countries that have supported it, but many of those that are supporting it are low and middle-income countries. So we need to actually have countries coming together in solidarity and putting their weight behind CTAP. And then CTAP had a series of recommendations, for example, for governments, including things like governments should encourage companies to, share intellectual property rights, to also share data, and they should have conditionality in terms of the public funding, because there's been a vast amount of public funding, which is fantastic for COVID-19 vaccines and other health technologies, and that's wonderful that we've had that public funding. But then there's also that question of, well, what conditions might be attached in terms of future public funding that maybe weren't attached in the COVID-19 context, in terms of whether further financing might enable countries to engage with CTAP. Perhaps it is, and certainly there are proposals that further financing might help move companies to engage with technology transfer proposals. But I think we also need to see that willingness of companies, and the more pressure that civil society organizations can put on companies, I think, and the more the TRIPS waiver gains this momentum, I think we're likely then to see more moves in favor of voluntary agreements if that happens. But the issue is, the Achilles heel of CTAP is it's voluntary, and we just haven't had the engagement. That's sadly the issue.
And I was wondering, maybe if investors as well could be sort of useful. One seeing now that on things like climate change, that investors are getting sort of nervous around, particularly petroleum companies, and that big pressure is being put on sort of divesting out of sort of fossil fuels. So if, say, some of the big pension companies and others start sort of trying to put pressure on companies to be more responsible and progressive, that might be a suggestion. One, you want to come in on this point?
Yeah, very, very quickly also, on this point. Exactly, because what we wanted to hopefully to prevent is more money to the big company without accountability, because there's already a missed opportunity. If we talk about CTAP, especially high-income countries who had an opportunity at the beginning of the pandemic, when there's a lot of public funding pulling into this space to accelerate R&D, not only upstream R&D, but also accelerate manufacturing, expanding and even de-risking the market. There's a lot of money there, but the mentality, the scenario, the kind of assumption is that the savior of this pandemic are big industry, which is fundamentally challengeable. So they lost the opportunity to see, this pandemic unprecedented. At that very beginning, there should be very clear accountability, not just encouragement, but mandatory enforceable requirement of sharing technology. And the government missed that opportunity. They shouldn't miss in the future. Well, now actually there's new funding start getting more pledged. So we think this should be one. But I think you mentioned the investors and also shareholders. I think those are very important stakeholder to actually to demand as well, realizing that now we're not just talking about one or two companies' IP, we're talking about the common destiny of the human society. To what extent some of the movement from climate change, I think you rightly pointed out, could be borrowed in the access to movement, because before the pandemic, it's more or less perceived as a developing country struggle, access to poor country, which we already disagree, but this pandemic shows it's everybody's responsibility. It's about our future. But to what extent the shareholder and investors would actually speak out, it's another question. We don't see much yet. To the contrary, many shareholders probably got a lot of profit, because each time when the vaccine company, others, before they have the final clinical data, there's a lot of press release going around, and then share price rise. So, but we really anticipate, you said that more stakeholders should start demanding.
But it's surprising, isn't it, that there hasn't been more pressure from the business community, given the benefits to the world economy. The airline industries and so many industries just sort of in effect shut down because we're not vaccinating the world fast enough. So it is surprising. Umanyanya, do you want to come in on this point?
Yeah, I just wanted to say that I think one of the things we have to be clear about is that the current access to medicines framework, the international framework, is fundamentally unfair. And it has resulted in extreme poverty, inequality, and countries that are burdened with debt, right? Because they're trying to procure medicines that are unaffordable. So we need to be challenging this fundamental kind of framework and say that, in fact, what we've seen through COVID is an alternative approach, actually, to this intellectual property approach, which is we spend our money on R&D as pharmaceutical companies. We are innovators. We need to be rewarded. We get rewarded by controlling the pricing, controlling the manufacturing, and controlling the procurement. And what we've seen with COVID is that the public investment actually was the thing that made us get to a vaccine in less than 12 months. This has never happened before. It happened because there was public investment and support of the pharmaceutical industry. So what we need to really recognize is that that is a different option. And it's a viable option, right? It's, the US government in the Operation Warp Speed spent $18 billion to produce a couple of candidates that have been successful. In fact, Moderna was almost 100% supported by the US government investment. So we've actually seen something that is completely contrary. It's completely de-risked, and therefore the pricing should have had the conditions that both Aisling and Ewan have talked about, could have been around global access to the technology, open access to the knowledge and know-how, and ensuring maximum capacity to manufacture these vaccines. This is a real life thing. We don't have to have UN high-level meetings about what are the different options, what can we do. We already had a UN high-level panel a couple of years ago on access to medicines that made these very points. Try different methodologies, have a prize system, have a royalty system where these companies do get something back, but they don't get to control and hold the world to hostage, essentially, with hoarding all the knowledge and know-how, having spent public money. And having had the guarantees of procurement, of mass procurement in the US and in Europe. And at the same time, you now have these same countries who had the opportunity to put into those contracts more solidarity mechanisms. Those countries are now saying, no, we can't have a TRIPS waiver because we need to protect our industries. No, we should have the kind of solidarity that was called for at the very beginning. You'll recall that there was all this talk about this is a public good. Whatever comes out of all of these trials has to be a public good. This is about the world. And everything turned around once those vaccines became available, and there was the hoarding by rich countries. And then the poor countries were sent to COVAX and ended up with no vaccine.
Mm-hmm. You've raised another very important point there, and it's this debate around the role of the sort of public and private financing, which is highly relevant to topic dear to my heart, and that's universal health coverage. And one question I'm dying to ask both you and Aisling is, do you see this crisis catalyzing universal health reforms in your own countries? Both South Africa and Ireland are sort of yet to make the transition to a sort of a predominantly publicly financed system. I'm conscious that in South Africa you've had your national insurance reforms, rumbling away for the last 10 years or so. That in Ireland there are the Sláintecare reforms, I think, that are proposed to create a universal publicly financed system. Are you seeing signs of the pressure of COVID helping the move towards UHC in your respective countries, or inhibiting it? So, Umiliana, maybe if you can start, and then I'll come into the audience next, I promise. So we'll just deal with these, and then we'll come to the audience.
Thanks, Rob. I think that's so important because it is about our national systems, right? Because people go to their local health facilities to get access to health services, vaccines, and so on. And I think what the COVID pandemic has shown is really the weakness of our health system and the deep inequality and deepening inequality in our health system. In South Africa, we have a public sector and a private sector. The private sector, as you can imagine, is very small. About 17% of the population who essentially, employed people who can afford that insurance are able to access private facilities, whilst 80% of the population accesses a very weak public system. And the weaknesses are primarily in the just lack of capacity, not enough doctors, nurses, ICU nurses, pediatrics, but also critically in governance structures. So we have a lot of problems with people being put into positions to run health systems that just don't have the capacity to do so. And we're seeing the further collapsing of those health systems. So what we really need to do when we talk about building back is to really think about how do we can't impose this kind of national health insurance scheme onto a very weakened health system. So what we need to do is really focus on building up that capacity within the public sector, utilizing the resources in the private sector, and finding ways. And when we do research and we talk to people about what is in the private sector, what is the thing that would change things, and they say very simple things like, let's train more nurses, let's have the private sector training doctors and nurses. That currently is not allowed in the legal framework. So there are a number of these kinds of low-hanging fruit that can help to build up the capacity within the public health system before we even think about this universal health coverage, which we all agree with. There's nobody who disagrees with the notion of universal health coverage, but the legal kind of instrument that's being used is essentially a financing system. It's a single payer system. That's what it is. It doesn't talk about, building capacity. It doesn't talk about standards in healthcare facilities. So that's happen. And unfortunately, COVID has further weakened quite a weak system already. We've had a lot of healthcare workers who have died of COVID. That's a significant dent in our resources. And so we need to think about rebuilding on many different levels at this stage.
Great, I see. You're sort of concentrating on the supply side reforms that will be necessary to launch it. Aisling, I was just wondering the situation in Ireland, you know, that we once seen, I think it's Cyprus that has launched UHC reforms in the midst of this crisis. Do you see sort of greater acceleration of the Care reforms in Ireland?
Yeah, so in the Irish context, there is some public health funding, but there's a huge amount of gaps, obviously, within that context. So many people wouldn't be eligible for, you know, medical cards, for example. And there's also a significant market for private health insurance in the Irish context. And as you mentioned, the Sláinte care reforms, they were, you know, introduced, but they have had a number of setbacks, kind of a 10-year plan for reform, and there's been delays to that, and there's some issues around funding. I suppose the pandemic, what it highlighted within the Irish context, with all countries, is the importance of healthcare, but particularly in the Irish context, I think it exposed some of the issues in terms of how our public health systems are actually set up. You know, the personnel in them did a fantastic job, as they did in other countries, in terms of COVID-19, but the COVID-19 pandemic highlighted actually how understaffed, for example, our intensive care capacity in Ireland was one of the smallest, I think, in Europe. So all of those issues were highlighted, and I think the public will be looking to see reforms in that in future, because those issues, you know, certainly would have been very concerning for many individuals due to COVID-19, but also more generally. You also see issues like, you know, wait times for A&E departments and etc. That can be quite long, again, because of shortages of staff, and staff then who are working in that system, they have often very difficult conditions in that context. So there is definitely need for greater resource. And I think COVID-19 has sort of highlighted some of the inequalities and kind of shown them up, and hopefully that could drive change in future. But again, issues of funding, you know, all of those issues will also probably play out in this context.
I mean, one thing that's interesting to note is that so many of the world's sort of great universal health systems have actually come out of crises. You know, you think it's sort of counterintuitive that just at a time that you know, economies are really battered and countries are really struggling, to do something like really bold, like introduce universal health reforms, would just seem like sort of a fantasy. But if you look at, you know, Japan and France and the UK, they all launched their UHC reforms when they're basically bankrupt at the end of the Second World War. And you know, you've got Thailand at the end of the financial crisis in 2001. Even Rwanda after the genocide, you know, one of the big moves of President Kagame was to introduce some universal health system. So we're very much sort of speculating that you are going to see some countries and some political leaders recognizing that they need quick political wins, and they need to do something to demonstrate that, you know, they do care for their populations. And so we're sort of tracking a number of countries where you think this might happen. Perhaps even in the United States, you never know. You know, this might be the time for the US to introduce a publicly financed system, but we'll wait and see that. So we've got some cracking questions coming from the audience now, and encourage others to join in as well. I think we've got sort of 4 open questions at the moment, and being very democratic, I'm sort of more than happy to ask them in the order that they're being upvoted at the moment. And the first one I'd like to put to you all, and also say to audience members, if they want to make themselves anonymous and want to sort of identify yourself, please do feel free to come and ask your question online. But if I can ask the first question at the top of the list, that's got 3 votes so far. I wonder what the panelists think about distribution of vaccines at a country level, and how the rule of law can help to ensure that vaccines go first to the ones that need it the most. I've recently heard about an online platform created in Lebanon to increase transparency and short-circuit corruption. Excellent question. You know, that we're seeing some countries, I think, allocating more based on health need and more equitably, and other countries where one fears that it's the well-connected who are sort of getting to the front of the queue and leaving the more vulnerable behind. So any thoughts on in-country distribution of vaccines and commodities, and sort of how the law can be used to ensure a more equitable distribution?
I can say what's happening in South Africa. with our limited vaccines, the priority has been to vaccinate healthcare workers. So they were first in the line, obviously, because they are the front line and were most at risk. And in fact, as I said before, many healthcare workers have died. I don't have the current number. But so there was a consideration of who were the most vulnerable. So healthcare workers were the first, but also then the elderly, who were also quite vulnerable. And the thinking was that the elderly, elderly being 60 and over, I don't know if that's the case in other countries, but 60 and over is also mirrors the kind of comorbidities that are linked to COVID-19, like diabetes, hypertension, and so on. But so the elderly and comorbidities in some ways were the next level of vulnerability. And right now we're looking at people in congregate settings. So in areas where people are living kind of in very high density places and have limited ways of social distancing and are vulnerable in different ways because of poverty. And so, you kind of go to where those people are and prioritize them for vaccines. And then, of course, we look at the next age group, which is 50 and over, again, very related to comorbidities like diabetes and hypertension, and then kind of everyone else. But I think critically, at the same time that you do that, you have to counter the misinformation around the vaccines. So many people, early on in the pandemic, the survey that was done said there was actually high levels of hesitancy even before we had, the final vaccines. So there were high levels of hesitancy, but right now we're seeing people are asking more questions. And there's a lot of work happening in South Africa on communicating and dealing with the myths around the vaccines, working with communities like churches, because what the evidence shows is that people really want to hear from the people in their communities, but also people that they trust within those communities. So that may be a traditional leader, it may be a religious leader, and it may be health professionals. But I think there's a need for a real drilling down and understanding of where the hesitancy lies and just addressing people's concerns, because the work that we do, we go out and train people in communities and go through everything from why this only took 12 months, like what really happened there, and getting people to understand the science of the COVID-19 disease itself, the virus, how it works in your body, what the vaccine actually does, what happens with treatment and so on. And again, that harkens back to what was done in the HIV epidemic, where the activists actually became scientific experts on HIV. And so they would go into the communities and be able to drill down into the details about the disease and why people can overcome the hesitancy that they had. So that's a critical piece that has to go along with distribution of vaccines.
Yuan and Ashley, thank you very much. Ashley and Yuan, any sort of thoughts sort of about the role of the law in ensuring an efficient and equitable rollout of vaccines within countries?
Yeah, I can quickly comment because what Rumiana shared is very interesting to see, because many of this community level of work are kind of jointly done from what I know in other countries as well by lawyers and scientists and community workers. Because when it's comes to in-country distribution, we think there's a kind of common understanding of principle goes, the first line, a priority should go to health workers, but not always like that. And also the frontline workers, and even have, stages of different age group and so on. So probably the country would have some of this guideline or regulation following WHO suggestions and guidelines. But then when it's come to the rule of law, I don't have the exhaustive knowledge of which kind of legal instrument each country are using. They probably use different type of instrument. But in order to make sure if the I think it's probably a few different level of work that the legal profession could help. One is when a country set up this priority order of distribution at the national level to maybe check to what extent it's actually going in line with what WHO is recommending, which is based on a lot of evidence of public health. But if the country has a legislation or regulation or guideline, whatever instruments are used to see, I think the example, I'm not super familiar with the Lebanon example, but I think that could be one very interesting approach to take to make sure that lawyers and together with others, community level of professions, scientists, medical professions really monitor to what extent the national guidelines are properly implemented on the ground, making sure there's no jumping off the queue. And then also making sure, I think one of the biggest challenges, as Umiana mentioned, even us in MSF, when we work with in countries, is the vaccine hesitancy and the contribution of misinformation and the missing trust contributing to the hesitancy. To address that, a lot of community level work are needed. Some countries probably have regulation and law to tackle misinformation directly, but then the misinformation need to be identified in the first place and then use the legal mechanism to tackle them more and together with building more knowledge from community, and then so people will have more trust on science and trust on this kind of mechanism of distribution.
Yeah, I haven't really heard of many sort of legal challenges to roll out strategies, but certainly it's a hot political debate, and I think it's one that we should encourage society to have. I mean, you don't just want one or two technocrats sort of looking at graphs and sort of making decisions that way. One very much does want to have debates about these things, and I think that we have seen some vulnerable groups in the UK that were being left out, and due to sort of publicity campaigns and involving the media and celebrities, them rising up. I'm thinking particularly of children with disabilities, and there was a sister of a very sort of prominent radio presenter who got very sick with COVID, and was used as a sort of very good argument as to why children with disabilities should be sort of prioritized. So we are going to definitely see huge debates about this, and one that I can sort of foresee is coming down the line where I think there will be legal implications will be about making vaccines compulsory potentially for people to be in employment in situations, if you're going to work in a care home, will you have to be vaccinated? And that how that's going to be challenged legally. I'm sure there's going to be lots and lots of debate about this sort of going forward. So I think a massive role for lawyers. And I think that might lead neatly into one of our questions actually about, do you think that law firms could have a role to play, maybe through their pro bono work, to support efforts to make vaccine available for all? And we have a big audience of lawyers with us today, so I'm just sort of wondering your thoughts on the extent to which the legal profession can and ought to be getting involved in these debates. Ashling, if I can maybe come to you first, I think you're a lawyer, aren't you? So what your thoughts are on this?
Yeah, I think it's an important role. I suppose I would like to hope that we as lawyers and people that educate people working in the law would sort of instill that public service almost rationale that anybody that has expertise could use that expertise in a way that would facilitate, I suppose, global goods. And I think the global good here, I think most would agree, is getting and addressing that artificial scarcity that exists currently and trying to get access more broadly. And if I can, I'll just mention briefly one other context, which isn't COVID-19, but another context in an area that I worked in the past was around gene patents. And some of you may be familiar with this and some won't, but I'll just very briefly explain. So in the US context, you had one corporation, Myriad, who had patents in relation to BRCA1 and BRCA2 genes. And any mutations on those, not any, but some mutations on those genes can give rise to an increased risks of certain types of breast and ovarian cancer in particular, of developing those. So obviously people that, maybe felt that they were in that category would like to get genetic testing. But one of the things that happened was that the rights holder, Myriad, had patents in relation to these genes and used those patents to stop other laboratories performing testing for a certain period of time. And the point of this is there was a number of legal challenges that were brought against Myriad patents. And those challenges were supported primarily, or at least largely, by pro bono practices. And were it not, I think, for the work of pro bono lawyers, I'm not sure that would have been successful. So you had the ACLU in the US, and you also had lawyers like Maurice Blackburn in the Australian context challenging patents in relation to this. And they led to successful challenges, and you subsequently had the isolated patents are no longer, or isolated genes rather, are no longer patentable in the US or indeed in the Australian context. And I think that pro bono work was so hugely important for a number of reasons. But one of the reasons is that patent litigation is extremely expensive. And many people that might be those that would have legal standing to challenge patents, if that's what somebody wanted to do, they may be members of the public, they may be patients, so they may not have the resources to put in those challenges. And I think when we think of that, and there's other examples as well I could give, pro bono work is so crucial in those contexts. But obviously pro bono work, it does take a lot of time, it is resource intensive. So there is that balance to be made, but I think the more that we can engage in pro bono, the more likely we are to have that broader public good. And I think in this context there may be a number of different avenues and a number of different areas within which lawyers could engage with trying to get global access to healthcare generally, but also trying to get global access in particular within the COVID-19 context, and not just in relation to COVID-19, but for example, much of the testing, cervical screening or other screening programs would have stopped during COVID-19 for, there was reasons behind that in terms of public health, but some of those issues were also exposed. There's other delays to treatment, and all of that might be areas within which pro bono could be useful, but in particular in I think the global access movement, it would be useful to have more, the more pro bono lawyers we get, the better, I think, in these areas.
Indeed, and maybe encourage lawyer friends to contact organisations like the People's Vaccine Alliance, who are really trying to fight this David against Goliath battle in terms of increasing access to vaccines, and I'm sure they'd be very much welcome support from the legal profession. Juan and Emiliano, have you any thoughts about how the legal profession can get involved in your areas of work?
Yeah, so, okay. We have actually, as Section 27, just applied to A for ID for support. And sometimes we just need some international research done. People who work in the international forums would have some idea of how those kind of principles, the human rights principles, would apply in South Africa. And so there are pieces of research that would support public interest litigation to have the kind of impact that we would like to have. Our constitution allows courts to consider international law and international jurisprudence. So it's always interesting. I mean, we can use Irish precedents to bolster our cases if similar matters have been heard in those courts. We rely quite heavily on Canadian jurisprudence and Australian jurisprudence, not so much the UK, but also kind of the international forums as well have great use to us as human rights lawyers. So I would encourage people to just make themselves available. And also when they do that work, to make that work available to everyone in an accessible form, so that, if you can just go on a website and see if any research has been done on a particular topic, that can be available to any human rights lawyer in the world. And then also, I think, encouraging your law firms to make donations to the organizations that are doing this work. Because many of them, Section 27 included, are donor funded. And we're always looking for donations to be able to do this kind of work. So very often when we go to a law firm and say, if you're interested in supporting this case, will you help us pay for whatever these costs are? And they'll say, we can give you pro bono support. And we're like, well, actually, we need money. But yeah, just like connecting with these organizations and seeing what their needs are. It may not be pro bono, but it might be something else. And to leverage the kind of resources within firms or clients or whatever the case may be, to really support the organizations that with very little are doing very high impact work and are making a real difference in people's lives around the world.
Fantastic, thanks very much. And what about from MSF's perspective? Can you always use some pro bono legal support?
Yes, definitely. So we're all wanting it. And so, yeah, we have been working with lawyers a lot, actually, from MSF's perspective and in my work. I mean, also thanks for organization such as A4ID, we actually have quite a number of project with them. And one of the flagship recent one is related to Ebola data sharing platform. And the MSF was advocating and trying to set up based on our experience during the 2013-2016 outbreak of Ebola. One of the experiences we had was that at that time, everybody was collecting samples and collecting data. A lot of it is lacking of coordination from research institutions and stakeholders. And then many of the data were scattered in different places without a clear governance, because it's related to a number of legal issues, including the patient's control of the data, control of the sample, how the data will be used for the future research, and so on. So we were trying to have some clear mechanism to say, okay, these are the data collected in that outbreak, but then it should benefit for people who are suffering from the Ebola, but also benefit of future research. How to set up an inclusive, accountable, viable data platform that the future research could benefit. And so we approached also A4ID, connecting us with law firm, and we got a lot of legal support to advise the possible governance structure, terms and conditions. So this kind of platform is already up running for the future research of Ebola. So those kind of advice and support are very much needed. And in addition to that, very similar to what Ashley shared in terms of challenging patents, we also work with many civil society organizations in different countries to challenge different type of patents. And we actually have a website called Patent Opposition Database. We have a kind of community of advocates and legal professions in developing countries mostly to identify the unmerited patent and then develop argument from different jurisdictions, analyzing some of the claims to see whether cases could be brought up in Brazil, in India, in Thailand, different countries. So oftentimes we know patent attorney are very expensive. It's very difficult to have a top layer attorney to help us analyzing the claims. But we did have some attorney who probably have a little bit spare time to look over one or two information for us, and some academics who probably practice as part-time also share their knowledge about the patent. So those kind of support have been very beneficial for us to keep this community up alive. So I think those would help us, especially in the sense of leveraging more legal space to support the production and supply. And also in terms of some of the ongoing discussion we have in a COVID situation and beyond, perhaps there is a huge role for public interest lawyers working on human rights cases to play in terms of checking state responsibility if there's a failure of developing delivering vaccine and therapeutics to people in need. Other areas work we have been not ourselves, but also with our partners seeking legal advice from time to time is the issue of transparency of contract and licensing that we are experiencing a lot in this pandemic. we still have a lot of trouble with that. We know there's some movement of Freedom to Information Act actions have been taken by multiple civil society in different countries with a different experience. Some of them really reach the point that need to go to litigation after administrative procedure, and we actually need a lot of legal advice how to strategically follow up those Freedom to Information Act, so that not only the specific licensing could be more transparent with less redacted text, but also the precedent setting for the future pandemic when more transparency could be resorted. Yeah.
Great, fantastic. Thanks very much, Juan. And I'm conscious of time and that we've got a sort of a couple of questions, but they're related questions. And I think it might be a good way to sort of wrap up really that our sort of colleagues are really asking around, well, for advice for civil society organizations who want to use the sort of rights-based approach and also get involved in debates here in Europe about sort of putting pressure on companies and governments on patent rights. So if I can sort of combine those two questions really with sort of some wrap-up comments for you, you know, reflecting on, you know, what we've been discussing today, you know, what would your advice be for activists, civil society activists and sort of legal activists, you know, wanting to engage in this space, you know, because it's a big tent, you know, we all need to work together on this. But so what would your advice be for colleagues who want to get involved and engage and have an impact in this area? And maybe if I sort of randomly start with Aisling first, and then we'll just whistle through the panel one more time.
I think it's an important question. I think the main thing is there is a space and a need for legal expertise, and many civil society groups really value that, and it helps to enable the arguments. If the arguments that are being made can be grounded within, you know, the legal context, and they can use those arguments to support. So I think anybody with the knowledge of, you know, human rights, or even, you know, company law, when you're dealing with shareholders in terms of their ability perhaps to engage in this context and to spur change, because we have had some evidence of shareholder activism in this context or in other contexts relevant. Also, when you have intellectual property frameworks and knowledge of the TRIPS framework and how that generally seems kind of more a commercial or trade-based area, but actually it has very important impacts on the access to health context. So bringing knowledge perhaps from people who didn't even feel that they were working in the healthcare context, people within the trade context, trade lawyers, commercial lawyers, who can actually bring their knowledge and their expertise, or knowledge and expertise of contract law, to bear perhaps on some of these issues. I think just being open-minded in terms of how various aspects of your wheelhouse and how creative you can be with aspects of your knowledge and expertise, and how that could be helpful perhaps to NGOs or to civil society when people are engaging with these issues. That's the main advice I would have. And just also, I suppose, you know, the kind of to encourage others to engage within this context as well.
Fantastic. Thanks very much, Aisling. And Juan, any specific advice that you would give our audience?
So for our audience, I think I agree with what Aisling said on civil society actions. Maybe final, I know we are running at the end. It's really, we need more lawyers. We need more lawyers in this movement. We are actually grateful. We do have lawyers like, you know, Umiana, Aisling, myself, we are lawyers, but we need more. That's a huge role for us to play as a profession, to really seeking justice, because that is our mission. If I kind of representing, but I can't represent, but I think that is our mission, to seek justice at the different levels. We really look forward for more pro bono support, because it could go to as high as enjoy and engaging international norm setting, but it could be as concrete as helping one victim in this injustice of access to medicine. So I think that's a huge role for us to play.
Fantastic, thanks. And Umiana, your reflections from South Africa.
Yeah, I agree obviously with what Aisling and Yuan have said. I would say as well, just do it, right? If you want to get involved, find a local organization and help support them. We as a movement, as civil society organizations, are incredibly generous. We support each other. If there's an organization out there that wants to know what's happening in a particular country, we're open to partnering. We've traveled to African countries to sit and work with organizations to help them build up strategies. So there's a lot of work that happens in solidarity, and that's really a characteristic of the space. And obviously we are concerned about human rights and justice everywhere. And so the work is cross-cutting across continents, across countries, and across sectors. So lawyers working with community activists is a really great combination. And so sharing and bringing those skills is really important. And lastly, I'd say just understand your own context really well. Understand what's driving poverty in your area and what laws surround those issues. Think about the global context. We know in COVID that about 125 million people are being forced into extreme poverty. This is going to be a real issue. And so understanding your local context so that you can influence the debate in those countries, but also be able to share your experiences across countries is a really valuable way to utilize the incredible tools that we have. I think we're very privileged as lawyers. And I think sharing that privilege and knowledge and skill is really important to all of us and makes a huge difference to people's lives. And that's really what we're about.
Fantastic. And one spot of advice from myself is that, watch the film Fire in the Blood. That will inspire you. Just how sort of a group of people, coming together from different backgrounds, be it sort of legal, political, scientific, really can change things. And definitely, again, another thing I think to think about is to get political. That it's far too often, I think, sort of people think, oh, I better not get involved in politics, that sort of, but at the end of the day, if you want to bring about change, you have to really. And I think that, again, we're sort of seeing political pressure on leaders. I mentioned already the demise of President Trump and maybe the likes of President Bolsonaro might go similar ways in Brazil now, the people very much reacting against the way that they've dealt with the crisis. And then it will be changes of government that will bring about the change. And just one very quick final plug for what we do at Chatham House. The whole sort of raison d'etre for our Centre for Universal Health is to engage in the political economy of health and health reforms, to try and bridge these gaps that exist sometimes between the medical profession, the legal profession, media, politicians, and sort of try and bring people together to have these discussions. So please to our audience and panelists as well, if you ever spot an opportunity where you want to have these discussions, do please bear us in mind, because that's what we're really here for and why I'm here with you this afternoon. But it's been absolutely fantastic discussion. I've really enjoyed talking to you all, and from the fantastic questions from the audience as well. I'll hand over back to Naomi now, and I'm sure she's got instructions with you for what's happening next. So thanks very much. Thank you.
Thank you ever so much, Rob. And yeah, I really second that. It's been a fantastic session. I've enjoyed every moment of it, and it's been a perfect arc for us to get from exploring the issues and then looking at what can be done and what the people who've attended this session can do. And I think that's just amazing, and obviously a starting point for more. I really want to thank each one of you. It really has been fantastic. We're really privileged to have you with us. And also the attendees who've participated in the session as well. We hope you've enjoyed the session and any other sessions you may have attended today at the conference. Tomorrow we have more events, including our session on SDG 16. We'll be launching the first chapter of the legal guide to the SDGs, which is a project of A4IDs, and that's exploring SDG 16 on peace, justice and strong institutions. So hopefully you'll be able to attend that. Once again, a huge thanks to you all, and I'm sure the participants will agree it's been a fantastic session, and I really hope you enjoyed it, and I hope we see you again soon. Thank you all.
Bye all.
Thank you very much.
Thanks. Bye-bye.